So a very good evening to all respected doctors, our distinguished panel of the very important the expert faculty members, and our distinguished honorable guests, all delegates, ladies and gentlemen. At the outset, Ms. Sandeep Mitra, on behalf of Curious Mankind Specialty, take this immense pleasure and the opportunity in extending a warm welcome to this best of ACC 2022. And it is in continuations of our sessions, which you must have witnessed yesterday. And it is the day 2 of the highlights, where we are going to cover a very important scientific and cutting edge updates in the latest cardiovascular science, which has been presented very recently in American College of Cardiology Congress. It is a great honor and the privilege for all of us, and we would like to extremely delighted and thanks to each one of you for joining this particular session over here. Dear Doctor, on behalf of the Curious Mankind Specialty, it's a great opportunity for all of us to welcome to this scientific conclave. As you know, the Curious Mankind Specialty is a dedicated team to serve the life of the millions of the patients with the cardiovascular disease across the country with the most highly quality and the affordable healthcare products and the services. And towards that, our strategic intent has been always to partner with some of the eminent national and the international societies and the congresses across the world throughout the year, and to bring to the best of the science being presented in those congresses during as soon as the congress gets over. So ACC is one of its kind in continuity of our scientific endeavor and the commitment. And in addition to that, our commitment is also there to provide some of the very relevant digital solutions for improving our patients' awareness and educations in the chronic healthcare space. And towards that, we have been forefront in the patient educations through the digital solutions like One Life and the Prana Life Force. And thank you very much for your support and for your encouragement and inspirations, without which it was never been possible. So with these few words, we would like to extend our warm welcome and the greetings. And may I now take this opportunity and the privilege and the pleasure of introducing Dr. Uday M. Jadhav. Dr. Jadhav, who is our session chair and the scientific program coordinator for this best of ACC. Thank you very much, sir, for accepting our invitations. And in continuations of our yesterday sessions, Dr. Jadhav, who is a professor and faculty of the Cardiology and Cardiac City Department, MGM New Bombay Hospitals, Navi Mumbai. Sir is going to start the sessions with your opening remarks and introducing the speakers of the day. Over to Dr. Jadhav. Thank you.
Thank you. Thank you very much, Sandeep, for getting us all together and the Mankind team. A great effort to take this initiative. I guess you have partnered us, all of you who are with us today evening, in the last ACC. So a year has passed in this COVID days. We exactly did the same thing last year for ACC 2021. And then we did it for the European heart failure and the ESC, and even the stroke meeting, which we have recently covered. So what we are intending to do is, on the day of the meeting, we are bringing some of the highlights from the best faculties with us. I have the pleasure and privilege to have with us Professor Dr. Sripal Bangalore, who I know over a period of many years. My earlier days of recognition with him was the early papers he had with Professor Franz Mizerli in hypertension and ARBs. Excellent orator, is the director of complex coronary intervention at the New York University School of Medicine in New York. And of course, we have Professor Dr. Deepak Bhatt from the Brigham and Women's Hospital, Boston, Harvard, who is the executive director of the interventional cardiovascular programs. We already have the SCORE and SOLOIST heart failure studies, which you may have probably looked at in the last couple of days. And Sripal Bangalore, of course, has tremendous amount of clinical studies of utility, which we practice in India. So welcome, sir, Professor Dr. Sripal Bangalore and Deepak Bhatt. And Sandeep, maybe start the first presentation as and when. Thank you.
Sir. Right, sir. May I request Dr. Sripal Bangalore is joined? In fact, I believe. Rahul, can you please check? I think he joined and then.
Sir, he has got some issue with his laptop, so he's just restarting and he'll join at any moment.
Okay, okay.
Right, Sandeep, till
Yes, sir.
so Dr. Shripal joins,
Yes,
let me capitulate what we did yesterday with the other two US faculties for those who have missed it. We had Professor Dr. Michael Weber and Jagat Narula, who shared with us some of the thoughts. And just to recapitulate, the spiral hypertension study was discussed by Michael Weber. And for clinicians in India, the interesting message is which came was, how do you use renal denervation studies? So it's back. It's like the phoenix, it rises all the time. And the spiral hypertension study has shown now that renal denervation studies in patients who have been optimized on the 3-drug medical therapy, the foundations of ARB or a ACE inhibitor and a thiazide diuretic and a calcium channel blocker like amlodipine to be specific, and continue to retain a BP beyond 140 by 90. In fact, it was beyond 160 by 90. Were well controlled with renal denervation therapy for ambulatory blood pressure, office blood pressure, and very safe, very important. There were no complications. So that was a very helpful study yesterday. Sandeep,
yes, I think I think Dr. Shripal has joined.
Okay, thank you. I'll stop here.
Yeah. Yeah, Professor Shripal, if you can kindly. I think, sir, he is still having some little issue. So if you can kindly continue with your commentaries.
So, that was one important study. The other study dealt with how do we take aspects of hypertension in pregnancy. So the traditional belief is that if you have a pre-existing chronic hypertension, then one need not lower the blood pressure too much. And in fact, going by the ACOG guidelines, less than 160 by 90 was also not desirable. So this was a very big study. The CHAP study looked at 5,000 patients and got the blood pressure down to less than 140 by 90, tried to ease it out to 130 by 80, and the results were absolutely amazing in terms of prevention of MACE, cardiovascular events, and hospitalizations, heart failures, safety for maternal endpoints, including all sorts of maternal morbidity. Very important. There was a safety for the neonatal outcome. So the whole fear that we always lingered in the mind of drop in the placental perfusion when you treat aggressively even chronic hypertension pre-existing is probably negated now, because the neonatal outcomes did not show any safety concerns. And nifedipine, retard, labetalol are very safe drugs. So the CHAP may now narrow down the gap between gestational and pre-existing hypertension. Probably the guidelines may have to be revised, and the inertia of how we approach hypertension in pregnancy will be very different, unlike our prior thoughts. So this particular study was pretty interesting in how we try and look for treating these patients. There were also two studies, one on hypertrophic cardiomyopathy, where there is an agent now available to reduce the LVOT obstruction and add it to the whole therapeutic armamentarium, which is very small basically, and therefore septal ablation is something now as an alternative to offer in these patients. And we have a monoclonal antibody, which in an intravenous infusion over 18 hours, very quickly, within a matter of 1 to 3 hours, can reverse the ticagrelor or antiplatelet effect. And therefore, when there is a bleed or there is a concerns about bleed, we are in a position to reverse it quickly and get it back to a point where patients can be operated or can be taken care of. And this is something that happens all the times in practice. Is Dr. So
Yeah,
Sandeep,
I feel he joined, but the thing
Yes,
is
yes.
yeah,
Please.
right, sure. Yeah, Professor Shripal, if you can kindly unmute. Yes, easy.
Okay, so can you guys hear me?
Yes, we can hear you. Right.
Yeah, so sorry for all the technical issues. For some reason, my computer decides to do some kind of a major update exactly at the wrong time. Okay, so okay, can you guys still hear me?
Yes, we can hear you. Yes, your screen is visible now. Yes.
Okay. So should we get started?
Yes, please.
Yeah. No, thank you very much for having me on. I think this year's ACC was very helpful because there were some major studies being presented there. So I have decided to show three studies which I feel like will have a major impact in clinical practice. So I'll show three of these studies which were presented as the late breaker at ACC, and we'll go into some of the discussions about each of them. So the first trial I thought would be potentially impactful is the PACMAN-AMI randomized trials. And of course, all of these slides are from the presenters themselves. So this is all available on the ACC website. So the PACMAN-AMI randomized clinical trial enrolled patients with acute MI, either NSTEMI or STEMI, who underwent successful PCI of the infarct vessel. And they also had to have two non-infarct related artery and non-obstructive lesions. So in other words, have a diameter stenosis of 20 to 50%. The other criteria for entry in this trial were the LDL should be more than 125 milligram per deciliter if they are not on statins. If they're already on statins and baseline, the LDL should be greater than 70 milligrams. The goal was to enroll 300 patients, and at baseline, all patients underwent IVUS, NIRS, and OCT. So comprehensive imaging, intercoronary imaging was done on these patients. There's also baseline blood sampling. And then the patients were randomized 1-to-1 to Alirocumab 150 milligrams given twice weekly. Once every 2 weeks, plus rosuvastatin 20 milligrams, or to placebo injections given every 2 weeks, or plus rosuvastatin 20 milligrams. And the key is that this was initiated less than 24 hours after PCI. So in other words, a patient underwent at an MI, comes in, you fix the culprit artery, and then the patients were randomized to PCSK9 versus placebo on top of statins. The follow-up was up to 52 weeks, and the patient again had comprehensive intravascular intercoronary imaging with IVUS, NIRS, and OCT. These were some of the follow-ups for this trial. The primary endpoint of this trial was not clinical. It was IVUS based and intravascular imaging based. So the primary endpoint was percent Atheroma volume. And of course, this is how you calculate percent atheroma volume. The powered secondary endpoint was maximum lipid core burden index, which is a measure of the lipid probability at the 4 millimeter with maximum lipid load of a vessel. So in other words, this is based on NIRS, and here you're seeing a lipid pool in an axial vessel portion of the coronary tree. So the powered secondary endpoint was this maximum lipid core burden index. The second, another powered secondary endpoint was change in minimal fibrous cap thickness. So this is an OCT image looking at fibrous cap thickness, and the evaluation was to see if there is a change in the minimal fibrous cap thickness from baseline to follow up between the two randomized treatment groups. The baseline characteristics, so we have 148 patients randomized to Alirocumab, 152 to placebo. You can see that the baseline characteristics is very well matched between the two groups. Diabetics were around only 10% of the cohort. And at baseline, I mean, prior to their MI, there are only 10 to 12% of patients were on a statin therapy, and around 5 to 6% of patients were on high intensity statins. So this is just at baseline. The other thing I want to highlight here is half the enrolled patients were STEMI. So STEMI patients, you fix the culprits, and then you have a non-obstructive disease randomized to PCSK9 with Alirocumab versus placebo. So these are some of the lipid changes in the trial. So in blue is Alirocumab, and red is placebo. So let's start with placebo. So the placebo patients started with the baseline LDL of around 150 milligrams per deciliter. And with the rosuvastatin 20 milligrams at the end of follow-up, you can see that their LDL cholesterol came down to 74 milligrams per deciliter. You know, the thing that I want to highlight here is with guidelines, we want to patients, depending on the guidelines, it should be less than 70. And in many cases, I mean, in my clinical practice, target less than 50 for patients with a prior MI. So you can imagine, even with the high intensity statins, patients' median LDL was only 74. In the Alirocumab group, the baseline LDL was around 154 milligram per deciliter. And as expected, there was 85% reduction in LDL cholesterol to a median cholesterol, LDL cholesterol of 24 milligrams per deciliter. And you can see this was achieved within 4 weeks and sustained to 52 weeks of follow-up. And so this is the primary endpoint of the trial, percentage change in atheroma volume. So we know from a number of high-intensity statin IVUS trial that high-intensity statins reduce atheroma volume, and that's what we saw in the placebo group, 1%, close to 1% decrease in atheroma volume. But with the Alirocumab, you see a greater degree, almost doubling of the reduction in atheroma volume, 2% reduction. So the difference was statistically significant at 0.001. And when you look at the maximum lipid core burden index, again, with the statins, there is a decrease, 37%, but with the PCSK9 added on top of the statin, there is an 80% reduction, difference of around 41, and you can see this p-value is highly significant. And finally, if you look at change in minimal fibrous cap thickness, again, statins increase fibrous cap thickness. So you can see a 33 micrometer increase in fibrous cap thickness from baseline, but this is almost doubled if you use a PCSK9, and this difference is statistically significant. And what I was more impressed is that this, of course, proves the hypothesis that it's all driven by LDL. So if you look at on-treatment LDL cholesterol and percent atheroma volume reduction, there seems to be kind of a strong relationship. So the lower the LDL cholesterol, greater is a reduction in percent atheroma volume. This is also true for a maximum lipid core burden index. So on NIRS, the lower the LDL cholesterol, the less lipid pool you'll see in these plaques, and there is a greater increase in fibrous cap thickness within a year of follow-up. And I was really impressed with this case example that was given. So I think maybe we can spend a few seconds on this. So this is a patient at baseline. So patient had IVUS measurements, and you can see percent atheroma volume is around 62% here. You can see calcific, fibrocalcific plaque and lipid plaque here. This is the NIRS data showing a lot of lipid plaque here. This is an OCT data showing the fibrous cap thickness measured at around 56 micrometers. And at 52 weeks, this is a patient randomized to Alirocumab on top of statins. And you can see visually there is a difference. The percent atheroma volume is now reduced to 50%. But to me, what's more impressive is look at what happened to the lipid pool. There is a significant lowering of the lipid pool on NIRS. And of course, here is kind of a paired OCT image, and you can clearly see that the fibrous cap thickness is thicker from 56 microns. It's almost increased by 3 folds, making this plaque likely less vulnerable compared to what it was at baseline. So the conclusion for this PACS-AMI trial is, compared to placebo, Alirocumab initiated in the setting of acute MI on top of high-intensity statin resulted in greater decrease in percent atheroma volume, larger reduction in lipid burden, and a higher increase in minimal fibrous cap thickness after 52 weeks of treatment. And these findings indicate incremental coronary plaque regression, lipid core reduction, and plaque stabilization with PCSK9, and provides a mechanistic rationale in favor of early initiation of very intensive LDL lowering therapy in acute MI patients. So I think now we are getting a growing body of data from PCSK9. I mean, we've seen data from Fourier and Odyssey outcomes about improvement in clinical outcomes, but this is starting early, and clearly we're seeing that there is a significant improvement in plaque characteristics, stabilization of plaque. Let me stop there. I'm not sure how we want to do. Do we want to do the discussion at the end? Should I keep going with the other two trials?
It's up to your comfort zone. I mean, whatever way you feel, if you want to just continue, we can do that. Otherwise, we can break and ask you a few questions on this study and then get on further.
Yeah, maybe let's do that. And since the studies will be somewhat different, maybe let's break for a few minutes and then have a discussion.
So I was going through this clinical study. Let me have a couple of quick questions for you, if I may. So let's look at our Indian delegates who have joined us today. The biggest problem with the PCSK9, the only available one is Eligibility in India, is the cost factor. It's pretty huge, believe me. Yeah. And therefore, it's not really, in a country with a modest economy, it just cannot be prescribed to even most of the deserving patients. Yeah. So let's say a patient would have a question for us, 2 questions. Number one is that if I take a statin for a 20 to 50% lesion over a period of time, will my, with a high dose statin, will my plaque stabilize reasonably good? Not as much as Alirocumab, but reasonably good. 1 and 2, will this data over a period of 1 year translate, though hypothetically it should, reduce the major events over a period of, let's say, 3 years or 5 years? How does it work?
Yeah, I think great questions. And I can tell you that even in the US, we have struggled with costs. And I think, even on the guidelines, and that's one of the reasons PCSK9, I mean, we all know it's very, very potent at reducing LDL, but it's not a front line because it's just, the major cost implications. That being said, I mean, forgetting costs for a second, we know from a number of studies that high intensity statins does cause a plaque regression and plaque stabilization. So I think the key message is we need to get the LDL down as low as possible. I mean, to me, the way I take this message, and specifically when we looked at those graphs where lower the LDL, you have better plaque stabilization, lipid. So what it tells me is, try to do everything you can within the context of that particular patient. So high intensity statins, add ezetimibe, lifestyle interventions to get to LDLs of like 50 or lower if you can. If cost is an issue, and if in certain patients, if cost is not an issue, I mean, this is a very potent, we know in every trial, we see 80% reduction in cholesterol. We do get that as low as that. And to follow up your question on the changes seen at 1 year, will it translate to clinical outcomes? I mean, you know, we have seen from Odyssey outcome 4-year and other trials, there's clear reduction in clinical outcomes. So this kind, to me, adds mechanistic insights to it. The reason I am actually interested in this trial is also, I believe in the fact that if a patient comes in with an MI, the time to do everything is when they are in the hospital. Because we've also seen a lot of therapeutic inertia. So many a times patients are discharged. There is a idea that you're going to up titrate your medication during follow-up, etc. Many a times, I mean, we have seen from a number of studies that never happens. I mean, there are patients, even after 1 year, they're still on a small dose of statins, etc. So this at least tells you that being aggressive in the hospital, PCSK9. I mean, that being said, in the US, we haven't reached a point that where we can get this approved in the hospital. But I mean, if I were given an opportunity, I would do this for my patients. But again, cost considerations are definitely an issue.
Has this study looked at any role of the small lipoprotein small a in terms of, does it contribute in any way to this change in the imaging parameters?
Oh, that's a great question. So I don't think they have specifically looked at the lipoprotein little a and to see if that was contributing or was it an LDL effect. For now, it looks like based on the data presented, it's more of an LDL effect.
Right. Thank you. I think we can go ahead with the second clinical trial.
Okay, so I think, okay, so let me share my screen again. Can you see my screen?
Yes, and just so you know, I've joined as well.
Hi, Deepak, how are you?
Good to see you, Shripal.
Good to see you.
Thank you.
Thank you. So if I understood right, you've got another trial to present, is that correct?
Yeah, I do have 2 more trials. We started a bit late, but Deepak, depending on your schedule, we can work around if you need to go sooner.
Yeah, because the organizers had initially said I would be done at 11:30 a.m. Then we pushed it out to 11:45 a.m. So I'll just have a hard stop at 11:45 a.m. at this point.
Oh yeah, okay. So I'll try to be quick with this. You know, on my screen, I'm actually seeing you. Can you guys see my slides?
No.
No.
Okay, for some reason it's kicking me out. Can you see me at my slides now?
Yes.
Okay, good. Okay, so the other 2 trials are related to quality of life. So what I'm thinking is I'll go through both of these trials. Maybe we can have a discussion at the end of this because it kind of highlights similar concepts. The first one is the complete trial quality of life. You know, I had the fortune to be part of this trial. So this trial was presented as a late breaker, effect of complete revascularization on angina-related quality of life in patients with STEMI. So we know the results of the complete trial. So the complete trial demonstrated that the complete revascularization reduced CV death or MI when compared to culprit-only revascularization in patients with STEMI. And in fact, we took this, I was part of the ACC/HA guidelines for revascularization. We took this and made it a class 1 recommendation for complete revascularization in patients with STEMI. And of course, the effect of complete revascularization on angina-related quality of life was not presented before. And so this was the background for this particular presentation. So we know the design of the complete trial, STEMI with multivessel coronary artery disease and successful PCI of the culprit lesion. Multivessel disease was defined as the patient should also have an additional non-culprit lesion, which had to be 70% or greater stenosis, or if it is 50 to 69%, you should have had a positive FFR. Patients were randomized to complete versus culprit-only revascularization. So here, as the primary results, the clinical outcomes has been published before. So the groups were pretty well matched, over 4,000 patients in this randomized trial. Since we are looking at quality of life, it's important to note that after the culprit lesion was revascularized, nearly half of these patients did not have any symptoms. So no angina in nearly half of the patients. So, and then you can see a breakdown of daily, weekly, or monthly angina. So the 37% of them had monthly angina. So not a lot of patients had angina after fixing that culprit lesion. And so this is the some of the results. So this is looking at the SAC subscale score at 6 months follow-up. What we can see from baseline is in both the complete and the culprit treatment group, the quality of angina quality of life scores improve substantially, but there is a greater improvement in the complete group compared to the culprit only. So here you see the differences. The difference between complete and culprit is in the magnitude of 1 to 2.5 points, and you see many of these p-values are statistically significant. So complete revascularization, better angina-related quality of life, and it kind of spans across many different domains. And this is also true at 3 years. So at 3 years, you can see a 1 to 1.5 point difference favoring complete revascularization in terms of quality of life, and compared to culprit only, many of these p-values are significant. And if you look at it in a different way, residual angina was defined as patients having any angina. So in other words, a SAC score, anything other than 100. It was 15.7% in the culprit group and 12.5% in the complete. So the absolute risk difference of 3%, p-value is significant. You only need to treat 31 patients. So again, favors complete revascularization for residual angina. One other thing which is with this presentation, which was impressive, was to look at non-culprit lesion stenosis severity. So if you have an 80% or greater stenosis severity, you can see that complete revascularization was favored in the subset of patients with 80% or greater stenosis. But if the non-culprit stenosis severity was less than 80%, there wasn't much difference between culprit and complete. So in other words, the result seems to be driven by stenosis severity of 80% or greater. And this is another way of looking at it, proportion with residual angina. If you have less than 80%, this difference was not significant, the culprit lesion versus complete, but complete revascularization made patients free of angina if the lesion stenosis was 80% or greater. So there was a greater absolute risk reduction with this. Let me skip this. So to conclude here, we've seen from the complete trial that there is improvement in clinical outcomes. And in this quality of life, again, we see that there were a greater proportion of patients who are free of angina with complete revascularization than culprit only. And this benefit was observed entirely in patients with non-culprit lesion stenosis severity of 80% or greater. And I think this adds to the growing evidence that in patients with TMA and multivessel disease, complete revascularization is the way to go. You not only improve clinical outcomes, but also quality of life, the two main things that we are interested in our patients. Okay, so in the interest of time, let me follow up that with the FAME-3 quality of life analysis. So FAME-3, we all know the results of the FAME-3 trial. FAME-3 included patients with triple vessel disease, randomizing them with the PCI with second generation drug-eluting stents versus bypass surgery. And of course, this trial was in, there was a lot of news and controversy of this trial, partly because of the fact that PCI failed to meet in non-inferiority criteria compared to CABG for the major adverse cardiac and cerebrovascular events at 1 year. But the key thing to emphasize for the difference is that there was no difference in death MI of stroke. The difference seems to be driven by repeat revascularization mainly. So the objective of this quality of life from the FAME-3 analysis was, in the light of small differences in clinical events, the impact of FFR-guided PCI versus CABG on quality of life, chest pain, and work status becomes more important for clinical decision-making. And so this was a quality of life analysis from the FAME-3 trial. So the FAME-3 was all-comers triple vessel disease, FFR-guided PCI, 757 patients, CABG, 743 patients. The inclusion criteria were 50% or greater diameter stenosis in 3 major epicardial vessel by visual estimation, no left main involvement. Exclusion were cardiogenic shock, recent STEMI within 5 days, or EF less than 30%. And the primary endpoint, this is a QOL substudy. So it was based on EQ5D, summary index between PCI and CABG at 12 months. And various different secondary endpoints. I mean, we'll go over some of these. I mean, these are very interesting. I think this will be helpful in clinical decision making. In terms of the primary endpoint, the PCI is in blue, CABG is in red. At baseline, you see there is not much a difference between EQ5D summary index between PCI and CABG. And 1 month, you see that the PCI is slightly better than CABG in terms of this summary index. And at 12 months, there is not much significant difference. The p-value was significant for the trajectory of improvement in EQ5D favoring FFR-guided PCI. So in other words, FFR-guided PCI, there was a faster feeling better, improvement in quality of life, mainly driven by improvement at 1 month compared to CABG, but at 12 months, there was not significantly significant difference between the two groups. This was also true for visual analog scale. Again, you see that at 1 month, PCI is better when compared to CABG, and at 12 months, there is no significant difference between the two groups. If you look at the proportion of patients with CCS angina class 2 or greater, you see at baseline close to 75% in both the groups had CCS angina class 2 or greater, and at discharge, very small proportion of patients had that degree of angina, and there was no significant difference between the two groups, and this persisted up to 12 months of follow-up. What I found interesting was this analysis looking at proportion of patients who are working full or part-time. So if you look at this at baseline, close to around 35, 37% of patients were working full or part-time in either of the groups. And at one month, you can see that this proportion slightly decreases in the PCI, but it's almost cuts in half by in the CABG group. So in other words, half of the patients who were working before stopped working. I'm sure they were trying to recover from the bypass surgery. And then patients get back to work, but you can see even at 12 months, there is a small difference. Overall, this was not significant. But if you look at the in the subgroup of patients, which was pre-specified less than 65 years of age, you see that this difference becomes more dramatic. Even though CABG patients get back to work, even at 1 year, there is more proportion of patients in PCI who are working full or part-time when compared to CABG. The other thing that was very interesting in terms of quality of life from FAME-3 was if you look at syntax score, the quality of life did not really matter whether patients were low, intermediate, or a high syntax score. No difference between PCI and CABG. PCI provided similar improvement in quality of life. So this will be my last slide. So in conclusion, patients with triple vessel coronary artery disease, quality of life at 12 months was similar between PCI and CABG. And but FFR-guided PCI resulted in faster improvement in quality of life and improved work status in patients less than 65 years of age. And there was the rate of significant angina was greatly reduced in both groups and was not different at 12 months. So I think this is very important data which will help us guide patient-centric decision making. Let me stop there. I'm sure turn it over to Dr. Bhatt.
Great. Well, thank you so much. That was really a wonderful series of presentations. Let me first make sure that I've got my slides up and that you can actually see them. So if I could just get a confirmation, do you see my slides?
Yes, they're very well seen. Yes, thank you.
Good. And are they fitting the screen appropriately?
Yes, they do. Yes, they
do. Good. And you can hear me well?
Very well, please.
Oh, okay. Fantastic. Well, then let me get started with my own recap of things that I thought were interesting at ACC. Really a pleasure to hear Dr. Bangalore speak. I got to meet him many years ago when he was an interventional cardiology fellow at Brigham Women's Hospital and Harvard Medical School. and I would say one of the most talented fellows to have gone through our program there. It's a pleasure seeing how well he's done in the program he's built up now at New York University. So as it turned out, I was actually going to cover many of the trials he picked. So I guess he and I have similar tastes. I thought the same ones he picked were really important ones. But in addition, I'm going to ask, because whoever is sponsoring this, I'm not even sure who's sponsoring this, but whoever's sponsoring this had asked me to cover some of the SGLT2 inhibitor data. So I'm going to now pivot from some of the more interventional trials to cover the SGLT2 inhibitor data that was presented at the meeting. And there were really two trials of note that were presented. The first was a SCORE trial, which I presented, and the second was the MPulse trial that Dr. Mikhail Kasaborod presented. So let me first start off with SCORE. Before doing that, these are my disclosures that are listed on this slide and relevant to the talk I'm giving on SCORE, which were sponsored by Sanofi and then Lexicon, is research funding for those companies paid to Brigham and Women's Hospital for my role as that study chair. And I'll also be talking about off-label and investigational uses of drugs, primarily sotagliflozin, which was a drug studied in SCORE. I've also got research funding from Boehringer Ingelheim and Lilly, who at least in the US are responsible for empagliflozin, the drug that is covered in the MPulse trial, also from AstraZeneca, who make dapagliflozin. I'm involved in some of the dapagliflozin trials. So the evolution of SGLT2 inhibitors in heart failure management has been nothing short of spectacular. This is a review article in Cell Metabolism along with Dr. Subodh Verma, who some of you may know, a cardiac surgeon at the University of Toronto, and Dr. Braunwald, obviously my boss here at Brigham and Women's Hospital and Harvard Medical School. And what was displayed here really is a summary of the trials over time of the SGLT2 inhibitors, a large number of clinical trials that have studied patients with diabetes, now also without diabetes, those with normal ventricular function, and even those with relatively advanced heart failure. Bottom line, all these trials have been very positive, showing significant benefits in reducing heart failure as an endpoint and also reducing kidney-related events. So an incredible series of trials and trial results. The SGLT2 inhibitors have multiple modes of benefit, primarily in the heart and in the kidney. Sotagliflozin, the drug that we studied in the SCORE trial, is an SGLT2 inhibitor and shares all these benefits. But it is additionally an SGLT1 inhibitor. SGLT2, as you know, is expressed in the kidney, the proximal convoluted tubule to be precise. And there's also some SGLT1 expressed downstream of SGLT2. But SGLT1 is also expressed in the gut. And inhibition of SGLT1 there leads to delays in glucose absorption. So a benefit that is independent of kidney function, or I should say a potential benefit. Sotagliflozin was studied versus placebo in the SOLOIST trial, a trial of patients admitted with acute decompensated heart failure. Everyone in the trial had diabetes. And sotagliflozin was found to produce a significant reduction in total cardiovascular deaths, hospitalizations for heart failure, and urgent heart failure visits. The benefit kicked in very early, and the absolute benefits as well as the relative benefits were quite large. Only 4 patients need to be treated for a year to prevent one event. And these results were published in the New England Journal of Medicine with respect to the SOLOIST trial. The SOLOIST trial, I'll remind you, was actually also the first trial ever to show a significant benefit in patients with heart failure with preserved ejection fraction, as well as a benefit in heart failure with reduced ejection fraction, something that was subsequently confirmed by empagliflozin in the EMPEROR Preserve trial. And in fact, that trial extended those findings to patients without diabetes, but with heart failure with preserved ejection fraction. So that was SOLOIST. SCORE also randomized patients to sotagliflozin or placebo, same primary endpoint of cardiovascular deaths, hospitalizations for heart failure, urgent heart failure visits, but in this case, outpatients, 10,000 plus outpatients with diabetes and chronic kidney disease were studied, unlike SOLOIST that was in patients with acute decompensated heart failure. So 10,000 plus outpatients with diabetes and CKD. And the results of this trial were also published in New England Journal of Medicine and showed a significant reduction in that endpoint I mentioned in heart failure events with sotagliflozin versus placebo. But interestingly, there was also a significant reduction in MACE, major adverse cardiovascular events, that is total cardiovascular deaths, non-fatal MI, non-fatal stroke, with sotagliflozin versus placebo, as was also published in New England Journal of Medicine at the time of that initial publication. And this benefit actually kicked in very early, statistically significant for MACE by around 3 months. I'm not talking about heart failure, where there was also a significant reduction by around 3 months in these outpatients with diabetes and chronic kidney disease, but here I'm talking about an early significant reduction in MACE. And this reduction included significant reductions in total fatal or non-fatal MIs and total fatal or non-fatal strokes. So these were results that were previously published in the New England Journal of Medicine. The American Heart Association listed SOLOIST and SCORED as among the top 10 advances in heart disease and stroke in 2020 and again in 2021. So now I'm going to share with you the new data that were presented as a late breaker at the ACC. And these data are specifically from the SCORED trial, where we examined the pre-specified subgroups of patients with a history of cardiovascular disease at baseline and those with no history of cardiovascular disease at baseline, approximately 5,000 patients in each of those subgroups. The pre-specified definition of history of CVD or cardiovascular disease included prior myocardial infarction, prior stroke, coronary revascularization, and peripheral vascular disease. There were multiple post-hoc sensitivity analyses that we did using different definitions of CVD, and for the sake of time, I'm not going to include those. Basically, those results match the results that I'm about to share with you. The endpoints we examined were total MACE, first and recurrent events, total MI, both fatal and non-fatal MI, and total stroke, both fatal and non-fatal stroke. And here are the results for MACE. In the patients first with a history of CVD, you can see the reduction in events, in MACE events with sotagliflozin versus placebo, and now in the patients with no history of CVD. So a hazard ratio of 0.79 in those with a history of CVD, and a hazard ratio of 0.74 in those with no history of CVD, with an interaction p-value of 0.76, meaning that the benefits are consistent in these two subgroups. Of course, as expected, the patients with CVD, either in the sotagliflozin or placebo arm, had higher event rates than those without CVD. That's, of course, common clinical sense. But the benefit, the degree of benefit in relative terms, was similar in these two subgroups. In this slide, and in all the slides I'm going to show, blue is sotagliflozin and red is placebo. So this is total MACE. Now let's look at total MI by CVD subgroup. In those with a history of CVD, a hazard ratio of 0.69 favoring sotagliflozin versus placebo. And in those with no history of CVD, a hazard ratio of 0.66, again, favoring sotagliflozin over placebo, interaction p-value not significant, meaning that the benefit is consistent in these two subgroups. And finally, total stroke, same pattern, consistent benefits in those with and without a history of CVD, hazard ratios of 0.69 and 0.62 respectively, and an interaction p-value that's not significant, suggesting consistent degrees of benefit in each of these subgroups. As well, in those with atherosclerosis, or I should say known, established, diagnosed atherosclerosis, there was a consistent benefit among those with coronary artery disease, cerebrovascular disease, or peripheral artery disease at baseline. Hazard ratios of 0.79, 0.72, 0.77, respectively. Again, interaction p-values not significant for all comparisons, meaning that the benefits were consistent across these three subgroups. And finally, I'll just mention side effects here. Adverse events of special interest, as was published in New England Journal of Medicine previously, and consistent with other SGLT2 inhibitors, higher rates of general mycotic infections, significantly higher rates of DKA. And the one thing that's different from other SGLT2 inhibitors is a higher rate of diarrhea, 8.5 versus 6%. Though new since that time of the publication in New England Journal of Medicine, we looked at the seriousness of diarrhea and other side effects listed here, and the proportions that were considered serious were similar between the groups, and adverse events generally did not lead to treatment discontinuation. Indeed, in the overall trial, the degree of benefit was consistent across these subgroups. The side effect profiles were consistent across the subgroups, but the rates of treatment discontinuation were essentially identical between sotagliflozin and placebo, indicating that the drug was tolerated as well as and as safe as the placebo overall. Finally, here is a meta-analysis of MACE for all the sotagliflozin trials, SCORED and SOLOIST, but also some phase 3 type 2 diabetes trials, some phase 3 type 1 diabetes trials, and some phase 2 type 2 diabetes trials. In total, over 20,000 patients, showing again a hazard ratio of 0.79, favoring sotagliflozin versus placebo. So some limitations to this analysis. The trial was stopped early because of COVID-related issues, but while that limited the ability to see significant reductions in CV death and limited the absolute risk reductions in MACE that were achieved, the results were still all statistically significant. We also ended up using investigator-reported events instead of adjudicated events, but I don't think in a blinded trial that should make any difference. So to conclude regarding this SCORED analysis in patients with diabetes and chronic kidney disease, sotagliflozin significantly reduced the composite of total cardiovascular deaths, hospitalizations for heart failure, and urgent heart failure visits by 26%, with a very early benefit that was significant by around 3 months. And I think this is a class effect of SGLT2 inhibitors. But additionally, total CV deaths, MIs, and strokes were reduced by 23%. This is potentially due to the SGLT1 effect of sotagliflozin on MI and also stroke. And this effect was significant by around 3 months as well, so an early effect. The MACE benefits were consistent across subgroups, including coronary, cerebral, or peripheral artery disease, and even in those without established cardiovascular disease. So ultimately, while the MACE effect could be due to SGLT1, it could also be that we studied patients with diabetes and chronic kidney disease at elevated cardiovascular risk, and maybe that's the right population in which SGLT2 inhibitors, even other ones, could reduce MACE. The answer to that question should be available from the EMPA kidney study, the press release of which said the trial was terminated early for overwhelming efficacy, but we'll have to see if that efficacy was just heart failure and kidney events or was also MACE. If it was also MACE, then I would say likely the MACE benefits are a class effect in patients who have high enough baseline cardiovascular risk, such as those with chronic kidney disease. So that is the SCORED trial recap. Let me move on now to the EMPULSE trial presented by Dr. Casaborod. And EMPULSE was a trial of acute heart failure, either HFrEF or HFpEF, either de novo or chronic decompensated heart failure, and importantly, with or without type 2 diabetes. And it was meant to complement EMPEROR Reduced, which was a positive trial, EMPEROR Preserved, which was a positive trial, DAPA heart failure, which was chronic HFrEF with or without type 2 diabetes, it was a positive trial, and SOLOIST, which I just briefly reviewed. And the main results, which have already been published very recently in Nature Medicine, showed that empagliflozin versus placebo provided significant clinical benefits. And this was a win ratio. The statistics may be a bit unusual to you, but the bottom line is there was a robust benefit of empagliflozin versus placebo on this win ratio. Now, the objectives of the particular late breaker that was presented just a few days ago at ACC was to evaluate the effects of empagliflozin on the primary endpoint of total clinical benefit in the EMPULSE trial, but according to the degree of symptomatic impairment of the patient at baseline, and to examine the impact of empagliflozin on the broad range of health status outcomes as measured by various domains of the KCCQ, that's the Kansas City Cardiomyopathy Questionnaire, and also the time course of these benefits. How early might they kick in? So these are once more patients with acute heart failure, stabilized, about 500 of them, randomized empagliflozin versus placebo, where the KCCQ is assessed at various time points. And the KCCQ, just to give you a quick recap, is looking at the quality of life of the patient. And there are various different measures, looking at things like physical limitations, quality of life, et cetera. The statistics I won't get into, they're well thought out, well done statistics. The baseline characteristics of the EMPULSE study are shown here. And this is a characteristic population of those with heart failure. As you can see, they defined EF as reduced if it was less than or equal to 40%, preserved, it was greater than 40%. Of course, the definition now has kind of changed to 50%, but I'll come back to that in a moment. And otherwise, overall, a very well representative population of those with heart failure. All right, well, let's talk about results. So here we're examining empagliflozin versus placebo, the primary endpoint, and tertiles of baseline KCCQ. Bottom line, a consistency of benefit, regardless of how symptomatic the patient might have been at baseline, a consistent benefit favoring empagliflozin versus placebo. Well, what about the effects of empagliflozin versus placebo on the KCCQ itself? Well, that's summarized on this slide with a very significant benefit, significant by 15 days, which is quite remarkable, of around 5 points. And 5 points, many would say, is very clinically significant on this KCCQ score. So significant benefit, meaningful clinical difference, early difference as well that was seen. And I'll note in the placebo arm, there's quite an improvement over time. That's expected. These were acute decompensated heart failure patients. Of course, they're going to get better over time if they survive. And that is not unexpected in the placebo arm. It also means there was lots of other good background therapy. But even despite that, an incremental, significant, important benefit of empagliflozin over placebo in how the patients feel as assessed by the KCCQ. And there were a bunch of other metrics of quality of life, physical limitation, symptoms, et cetera, that were examined. And these were all consistently favorably influenced by empagliflozin versus placebo. Multiple subgroups were compared for the empagliflozin versus placebo on KCCQ at day 90. Bottom line, consistency of benefit across multiple subgroups. Importantly, those that did and did not have diabetes at baseline. So that's a really important message, I think. Benefits in males and females, benefits in those that were enrolled with de novo heart failure or decompensated chronic heart failure. And some more subgroups here as well. Baseline BNP didn't really seem to influence things, AF status, but the important one here is EF, less than 40 or greater than 40, a consistent benefit. Now, they didn't actually present the 50% less or more, but I was the discussant for this trial at the late breaking sessions at ACC. I asked that question, what if you cut it by 50%? And Dr. Kosoborod said there were very few patients, but it seemed like the benefits are consistent in this class of medicines in patients across the full range of ejection fraction. And I agree with that. But he said there weren't really that many patients in this particular trial with EF greater than 50. The responder analysis also, again, shows benefits, defining it, a responder is greater than or equal to 5 points on this KCCQ scale, and even by larger increments, 10, even 20 points, results favoring empagliflozin versus placebo. So it looks like the majority of patients get a benefit, some get a really big benefit. You know, there are limitations to this as every analysis. KCCQ was a predefined secondary endpoint. There were prospective assessments of KCCQ domains that were pre-specified, but a number of the analyses were post hoc. And it's a relatively modest sample size. So, you know, it didn't really have sufficient power for the responder analyses, not sufficient power to look at EF greater than 50 or greater than 60%, but nonetheless, very consistent benefits across, I would say, the full population studied. So what the authors concluded was the treatment with empagliflozin produced total clinical benefit among patients hospitalized with acute heart failure across the entire range of baseline KCCQ. This indicates that the benefits of empagliflozin in this group of patients are independent of symptomatic impairment at baseline. So just because the patient feels well doesn't mean you shouldn't implement therapy, you should. Empagliflozin significantly improved all the key KCCQ domains, collectively encompassing symptoms, physical functioning, quality of life, even social functioning. And the benefits were generally consistent across demographic and clinical characteristics and seen as early as 15 days, so 2 weeks, and maintained through 90 days. So really, this is an important message why you should start SGLT2 inhibitors as long as there are no contraindications in these types of patients with heart failure early. Otherwise, you lose some of these early benefits if you wait to see them in the office 2 weeks later or a month later, for example. And this work by the authors was published in Circulation. Well, with that, I'm at my 20 minutes. I'm going to wrap up my presentation. Happy to take any questions about these presentations, Dr. Bangalore's presentations, or for that matter, anything that came up at ACC that we didn't have the time to cover. Thank you so much. It's always a privilege to be able to speak to physicians from India. I'm really happy to have received this invitation. Thank you.
Thank you, Professor Dr. Deepak. That's wonderful. We have been looking at this study last 2 days on all sides that have put it forward. A quick question is, so do you see that SGLT1 inhibition as a concept will have additional score points over the SGLT2 inhibition?
That's a great question. So first of all, sotagliflozin is currently not FDA approved, but the company is putting in for FDA approval. So we have to see whether they get it or not. If they get it, then it'll be a new option in the US and then hopefully eventually in India as well. The drug is approved by the European Medicines Agency, but for type 1 diabetes. So we haven't yet applied there for a type 2 diabetes indication. So it's not available. So right now, it's not a direct option, but there are a bunch of companies that are investigating SGLT1 inhibitors in combination, SGLT1, 2 inhibitors, and a lot of basic scientists doing research. What I think we can confidently say right now is that the class of SGLT2 inhibitors reduce heart failure and kidney endpoints. The most recent ACC/AHA guidelines for heart failure just came out at the ACC, and they very strongly endorse the use of SGLT2 inhibitors. And by that, I mean the class. Use whichever one is available to you. Use whichever one might be cheapest to you. But certainly empagliflozin, dapagliflozin, canagliflozin, erdagliflozin, and sotagliflozin, those specific SGLT2 inhibitors have very good to excellent amounts of data supporting their cardiovascular benefits, as well as their benefits on glucose control, weight, blood pressure reduction. So those are class effects. As far as the other SGLT2 inhibitors, other than sotagliflozin, some have shown perhaps signals in reducing MI, none have shown signals in reducing stroke. So it does seem like that might be SGLT1 specific, but again, EMPA-KIDNEY, we have to wait and see what it shows. There, the press release that just came out in the past couple of weeks, said the trial showed overwhelming benefit and was stopped, but it didn't specifically say what the benefits were. I'm assuming they're in heart failure and kidney endpoints, but if they see a reduction in stroke, then I'd say, okay, it's a class effect. You just have to get patients that are at high risk for MI and stroke. And if they don't see a reduction in MI and stroke, I'd say, yes, there is something beyond other SGLT2 inhibitors with the SGLT1 inhibition sotagliflozin affords. But, have to wait and see what EMPA-KIDNEY shows and the results. Again, they know the results because they issued a press release. I don't know when the trial will be presented and published, but I would assume that they'll come out in the next few months.
Another quick comment from you is the concern, whether there should be a concern for diarrhea. India has one of those, remogliflozin, which is probably a little lesser selective than SOTA for SGLT1 inhibition. And the experience over the last couple of years, including whatever clinical trials even we have been involved with, we do not see in real life practice that level of diarrhea. You think that's going to be a concern?
I haven't used that particular SGLT2 inhibitor, but I think the experience you related is very valuable. I think with sotagliflozin, if it gets approved, the diarrhea is not going to be a real issue because, again, we looked at study drug discontinuation, hospitalization, hypotension, or things like that with the diarrhea, and really we didn't see any significant major differences versus placebo. So it's kind of a minor sort of a nuisance. It was a 2% absolute excess. So, most patients, it's about 6% in placebo, 8% with the drug. So most patients weren't having any diarrhea. And in the majority of cases, even those that did, it didn't lead to study drug discontinuation. They continued it. So I don't think that's going to be a real issue or a major obstacle, assuming the drug gets approved.
Thank you. Professor Dr. Shripal, will you have any comments or questions for Dr. Deepak?
No, I think these data are so wonderful. Like, we always talk about, are they the next statins? I mean, it looks like SGLT2 inhibitors are useful in patients with diabetes, without diabetes, with CKD, heart failure, name it. So I think it's very exciting. And one of the things that when we did the ischemia CKD trial, in patients who have kidney disease, no matter what we do, we can't reduce their event rates. I mean, it's great to see medications like SGLT2 consistently reduce cardiovascular endpoints.
Yeah, it's interesting to hear what Dr. Bangor just said about these statins. In fact, Dr. Brownwall just recently had a very nice piece in the European Heart Journal where he said SGLT, or the title of it was SGLT2 inhibitors, statins of the 21st century. And, I think that he's right. I mean, the mechanism of action, of course, isn't the same as statins, but I think SGLT2 inhibitors will be used as commonly as statins in the future, probably just in the next few years, especially, once the drugs start to go generic in the US, at least they're all branded, but in 2025, 2026, they'll start going generic. And at that point, I think they will be used as widely as statins for patients with diabetes, for patients with heart failure with or without diabetes across the full range of ejection fraction, and for those with chronic kidney disease with or without diabetes.
Thank you, Professor Dr. Deepak. Thank you for your time today. I know you have a meeting just coming up, so thank you for.
Yeah, actually, I was. My secretary was very good. She just pushed it back, so I've got time here to continue any discussion we might have.
All right, then that will be very helpful. Professor Sripal, if we can take all this quality of life, I mean, how things have changed over the last couple of years. If you look at SGLT2, ARNI, everything talks about initiating early and getting a better quality of life, and very early, in fact, and besides the reduction of events. And then we go back to the 2 clinical trials you have. And if you may want to pass on a message, and let's quiz you on that for patients of STEMI and patients of non-STEMI, culprit lesion revascularization versus a complete revascularization, and then FFR guided or otherwise, what will be your combination of these 2 aspects, the reduction in events and quality of life that you highlighted? What would be your messages for us today?
Yeah, so I think in terms of, if I can just step back and say, why do we want to do something invasive? For example, why do we want to revascularize patients? The main things that we always talk about is, can the patient live longer or feel better, or a combination of both? I think that's kind of overwhelming principles that we use for clinical care, and I think it's great to see all of this, specifically in STEMI patients, multivessel disease, reducing clinical events, which itself is great, but again, from a patient perspective, I mean, making them feel better, I think should be the topmost priority, because there are many therapies that we use. They may not improve their clinical endpoints. There may not be significant difference, but if you can make them feel better, and this has also been shown in a number of survey analysis, patients value feeling better to be one of the topmost priority. And I think that's what the consistent message we're seeing. So in my clinical practice, if I have a STEMI patient with multivessel disease, I try to be as complete as reasonably possible. I mean, the reason I say reasonably possible is we may also have a patient who is 80 years old and or older, and it may not be within the goals of care to try to completely revascularize, etc. But in majority of patients, that's what I try to achieve, not only to improve clinical outcomes, but also improve their quality of life.
What about the FFR guided strategy? How do you look at that for the non-culprit?
Yeah, so the FFR guided strategy, I think it'll take a lot more time to discuss, because the nuances, I mean, we now have a number of clinical trials looking at ACS patients versus stable coronary artery disease patients. And, the data is kind of variable, because if you look at ACS patients, imaging and plaque quantification may potentially be important, but the way I use any kind of physiological indices is to see if it is significant to drive decisions of whether patients need revascularization.
All right, Dr. Deepak, we have a couple of very interesting questions that have come up. So this comes from Dr. Raval, who comes from one of our coastal places in Gujarat, the state of Gujarat, Khambat. And he says, when you look at SGLT2 inhibitors, and then we can talk about statins too, because there is a question following it, is the long-term decline in cognitive functions? Do clinical studies or the new therapies need to look at it carefully, whether it's ARNI or SGLT2 or statins?
Yeah, I think it's a really great question because it comes up all the time in clinical practice. So first of all, let me just start with statins. There's really no good evidence that they cause cognitive dysfunction, despite the claims on the internet that they do. The randomized clinical trials that have evaluated this very carefully have found zero evidence of cognitive dysfunction, despite the fact that, of course, there are patients, even some doctors who are patients, that say that they're having cognitive dysfunction. But this is clearly a nocebo effect. That is, when patients, even intelligent ones, believe a drug can cause a side effect, it will cause a side effect. It's like if you tell patients, yeah, beta blockers can cause fatigue, well, a proportion of them will feel fatigued, even if they're getting a placebo, but you've told them it causes fatigue. The nocebo effect is the opposite of the placebo effect. The placebo effect is therapeutic, where we give the patient maybe a vitamin B12 shot and they feel that they're full of energy, even though they don't have a low vitamin B12. It's a placebo effect there. It's the same sort of thing, but in the opposite direction. So let me make it clear, there is no debate or controversy, at least among experts. Statins do not cause cognitive dysfunction. The opposite, they actually reduce the risk of ischemic stroke and therefore, could potentially reduce cognitive dysfunction in that mode of action over time. Likewise, PCSK9 inhibitors have been studied very closely, and even patients where their LDL cholesterol is decreased to single digits within the time frame of study in those studies, which is a few years, no evidence of cognitive dysfunction. Again, those drugs reduce stroke risk. So if anything, might be expected to have a benefit on brain health. As far as ARNI and SGLT2 inhibitors, the issue hasn't been studied as closely, but to date, at least in terms of adverse event reporting in the randomized blinded clinical trials, there's no evidence of any sort of cognitive problem. Once more, these trials are reducing important events. In the case of ARNI, with heart failure with reduced ejection fraction, mortality is reduced. So I wouldn't, actually worry about theoretical side effects, especially when there isn't a good science behind why one would even expect cognitive problems with ARNI or SGLT2 inhibitors. Likewise, SGLT2 inhibitors in the meta-analyses in high-risk patients, such as those with heart failure with reduced ejection fraction, reduced cardiovascular and all-cause mortality. So once more, I wouldn't worry about using those agents because of that very theoretical risk. So bottom line, I wouldn't worry about it right now. But should we look for that in trials? Yes, we should continue to look for those sorts of things in trials, as has been done.
And that brings me to the other question for both of you. As he says, we use the higher potency of statins and a higher dose of statins. Do you see that as upsetting the glycemic index of a patient, creating more hyperglycemia, or getting it more difficult to control their blood sugars?
Terrific question. It's been shown in randomized clinical trials that high potency, high doses of statins can slightly increase the risk of diabetes. That seems to be a real finding from randomized blinded trials. Of course, it's a little bit tricky to sometimes do those analyses, because if the statin is keeping you from dying, then, of course, if you're living, you have a greater risk of developing diabetes or cancer or other competing causes of non-cardiovascular mortality. But even putting aside those theoretical, statistical, and trialist considerations, it does appear that statins at high doses, high potency, do slightly increase the risk of diabetes. But to me, in patients that have indications for statins, the benefits in terms of reducing MI, ischemic stroke, potentially peripheral ischemic events, and retarding the progression of atherosclerosis in general, and over time reducing cardiovascular and all-cause mortality outweigh those sorts of risks. Even in trials like Jupiter, low-risk primary prevention, mortality was lower with the statin, in that case, rosuvastatin versus placebo, though the risk of diabetes was slightly higher. So, I don't want to ever say that statins or SGLT2 inhibitors or ARNI or any drug class is side effect free. They all cause side effects. If you can naturally get your cholesterol and glucose and everything in good shape, then do it naturally. But for patients with actual atherosclerosis or at very high risk of it, these therapies are potentially life-saving, and we should be aware of those side effects, but we shouldn't not prescribe because of fear of those side effects. Having said that, in patients on high-dose statin therapy, they should be monitored for diabetes, but those patients should be monitored for diabetes anyway, because if they're on a high dose of a statin, they probably are at-risk type of patients. And in the future, we may have alternatives to statins that don't cause diabetes. The PCSK9 inhibitors, for example, don't. Ezetimibe doesn't. As best we can tell, bempedoic acid doesn't. So there might be other alternatives, but other than ezetimibe, they're all going to be expensive, at least for the intermediate term.
Yeah, just to amplify that, I must say that there are also studies, for example, in the TNT trial, we kind of know the profile of patients who are more likely to develop diabetes. I mean, these are mainly patients who are kind of in the metabolic syndrome range. So in other words, they are patients who had higher fasting glucose, they are obese, etc. So in other words, it seems that the profile of patients who are more likely to develop diabetes are patients who are kind of in the pre-diabetic range to begin with. It's possible that the statins just pushes them over the edge. But I must amplify what Dr. Bhatt is saying, that the risk is extremely low. The benefits far outweigh the risk.
Yeah, that's an important additional point.
We have lost few minutes, so let me ask you on one of the studies, Professor Deepak, was, and this is crucial for the clinical understanding, the restriction of sodium in patients of chronic heart failure, getting it less than 1400 consumption of sodium to the standard. And they've shown that the restriction of sodium really did not change any event reduction. And I mean, restricting salt in the diet beyond the extent, there are clinicians who simply cut off salt completely from the diet for this heart failure patient. What's your take home on that?
Yeah, I'm glad this study was done because this has been a controversial area. Salt in general has been controversial with respect to hypertension, with respect to heart failure. The data for hypertension, and I'll be interested to see what Dr. Bangler thinks. He's done a lot of great work in hypertension. The data for hypertension, I think, is more clear. That is, if you're taking in over 3 grams of sodium a day, that's going to contribute to high blood pressure. In some cases, if it's like 4 or 5 grams a day, that's going to contribute to resistant hypertension. It'll be very hard to control the high blood pressure. But, once you're under 2 grams a day, is there incremental benefit of even going lower? I think the benefits sort of get outweighed by the difficulty, at least for the average Westerner, to do that. And I think that applies in India as well, where diet is kind of salty many times. I think for hypertension, there is a benefit, but it probably, like most things, sort of levels off and gets diminishing returns because many people struggle with a 1500 limit and then end up sort of overcompensating. I think binging is really bad. That is, I think, an enormous amount of salt intake, if you already have a history of heart failure or atrial fibrillation or high risk of that, we've all seen that happen where patients decompensate from that sort of binging of salt and other bad food when you're, perhaps binging on salt-containing foods. Now, for heart failure, the trial, strictly speaking, was negative. There were some improvements in how patients felt, if you're willing to sort of be permissive about p-values and secondary endpoints and that sort of thing. But for the primary endpoint, the trial really didn't achieve it. So, we don't have now level 1 evidence to support just saying, be restrictive with salt. But one thing to be careful about with randomized clinical trials, again, these weren't patients, getting in, 3, 4, 5 grams of salt a day, right? So these are good patients that got into a randomized clinical trial. These aren't really, our daily patients who are eating a lot more salt than in the control arm of the trial. So with that major caveat, I'd say to use common sense, but at this point in time, I wouldn't torture or punish the patient, making them go to an extreme degree of reducing their salt. But, I'd be interested to hear what Dr. Bangler says about the salt issues and heart failure and even hypertension.
Yeah, so no, I completely agree. I mean, Franz Mazzarli and I have published a couple of these. I mean, it's fascinating. I mean, the whole issue of salt, because there seems to be more data on sugar and the harmful effect of sugar. And interestingly, if you look at what has happened in media and everywhere else, we seem to focus more on salt. I mean, that being said, I mean, all of these trials should not be kind of a green flag to say you can eat whatever amount of salt. I mean, clearly in every epidemiological study, whether it's hypertension, heart failure, if you eat a lot of salt, you're going to have bad outcomes. The question is always how restrictive should we be? And in some studies there have been J or U-shaped curves. If you go too low on your salt consumption in hypertension patients, I mean, depending on whether you're a salt-sensitive person or not a salt-sensitive hypertensive patients. So I think to my way of thinking about this is, what is the optimal salt restriction? I mean, is that, I mean, we clearly know from the trials, it's likely not going to be less than 1.5. Is it 2 grams? Is it 3 grams? But clearly the message to our patients should be, if you are a high-risk patient, whether it's hypertension or heart failure, you should limit salt intake. But of course, you shouldn't go to that extreme levels that you should reduce it to less than 1.5, because compliance also matters, because many a times if you try to drive them to that degree, they may be compliant for a couple of days or weeks, and the compliance plummets, and then they start going back to what they were doing before.
Yeah, I think that's really good common sense advice. I mean, it's like telling patients to lose weight. You should do it if they're overweight, but when you give them something really extreme, it's hard for them to stick with that. It's hard for any of us to stick with that. Other things for people that worry about hypertension, I think Dr. Bangalore made a good point. I mean, in real life, those things don't move in isolation. The people that are eating a lot of salt are usually also eating a lot of sugar, and that has some bad effects with as well. They're usually also taking in a lot of calories and a lot of unhealthy calories. And those things often go together. There's often a lot of alcohol consumption with that very salty food. So, that we know very clearly now that alcohol is a trigger for atrial fibrillation. Even one drink a day can actually trigger atrial fibrillation. And this wasn't actually presented at ACC, but just in the week or so before ACC, there was a nice publication in JAMA Open. The senior author, one of my former fellows, Krishna Aragam at the Mass General. And what they did was look at the UK Biobank, enormous observational study, and found that even a drink a day raises the risk of hypertension, atrial fibrillation, as was known, but also of coronary artery disease. There's that old thinking that a drink a day prevents coronary artery disease. It's very widespread. I know in the US that belief, and in Europe. But the observational data are largely confounded because we tell people that are sick or on medicines or on warfarin or things, don't take your, don't drink. And that leads to a healthy sort of user effect. But in this very carefully controlled analysis of the UK Biobank, I thought it was very well done, really shows, or I should say suggests, it's not a randomized trial, but it strongly suggests that there is no degree of alcohol intake that actually provides cardiovascular protection. There's a little increase in a variety of different cardiovascular endpoints, including coronary artery disease. So if people are really worried about hypertension, that sort of thing, I think the best diet is probably a plant-based diet, one that consists of whole grains and fresh fruit and vegetable, and is a relatively low calorie diet. Beyond that, I think everything else is speculative.
And what is your final take on the water intake for this chronic heart failure patients? Maybe not the end stage heart failures, but otherwise you also would be a little liberal with the water intake?
I let people's, hypothalamus and brain dictate that sort of thing. I think if people are thirsty, you got to let them drink. I think if you try to restrict water, sure, if someone's in the hospital, acute decompensated heart failure, the nurse is keeping measurements, it'll work. At home, it never really works anyway. So I'd say if they're thirsty, drink, but if you're not thirsty, don't just drink. Of course, some patients have gotten the advice, drink 8 glasses of water a day. It's good for your kidneys, et cetera. There's that thinking that's been out there for decades that even if you're not thirsty, there's some health value to drinking nice, clear water. I would say don't drink anything if you're not thirsty, but if you're thirsty, yeah, sure, go ahead and have some water. And you can always adjust the diuretic dose as needed. But I think trying to get people to restrict, the urge to drink water when your brain is telling you to is very strong. I think trying to get people to resist it, yeah, it'll work for a week or two when they're in the hospital, maybe a week after discharge, but I don't think it's sustainable.
Any final comment, Professor Sripal, and we can then wind up.
No, I agree. I think ACC was wonderful. A lot of interesting science coming up. I mean, we didn't even talk about other things in the pipeline. So I think in the next 5-10 years, I think we'll have wonderful medications. So hopefully we should be able to drive down all of these cardiovascular events to pretty low numbers.
Yeah, I agree with those comments. And I would just add, we didn't really discuss everything that's coming is quite true, even on the interventional side. I mean, that complete analysis I thought was excellent, but complete 2 will be starting, I think, sometime soon, according to Dr. Mehta from McMaster. And that's actually going to randomize patients to angiography or FFR/IFR in terms of the best strategy for complete revascularization in patients with STEMI or NSTEMI. So we're going to learn a lot more about the optimal mode, completeness, adjunctive imaging, or hemodynamic assessments in patients with coronary artery disease. So a lot more interesting stuff to come in the next few years.
Thank you very much. I guess today's session follows what we discussed yesterday also. One of your studies on the ticagrelor or reversal agent for the bleeds. That was a great, interesting presentation yesterday. And we also did discuss the new areas of hypertrophic cardiomyopathy. Besides the septal ablation, the newer drugs that would probably help us. So ACC has been phenomenal this year. A lot of good learning curves, and then we have at least stepped out of our COVID days, and probably there is an option now to meet people and exchange more ideas. So thank you very much, Professor Deepak Bhatt and Shripal Bangalore. I'm really thankful to you. You did stretch your time and made it all possible till beyond the scheduled time of 9:50. Thank you very much once again. And the entire team from the back team from Mankind, Sandeep, and the entire team, thank you very much. So my colleagues and friends, we have really had a great time, and we look forward to you for all these meetings as we cover the scientific sessions of the important meetings like the college meeting. Thank you very much. Sandeep.
Thank you so much, sir. Thank you. Thank you, Professor Bhatt. Thank you, Professor Shripal. Thank you, Dr. Jadhav. That was truly brilliant. In fact, as you rightly pointed out, ACC has been always phenomenal. And this year's too, also some of the cutting edge science, which you could actually get an opportunity. Thanks for your valuable time and joining this particular sessions. Hope everyone in the audience have thoroughly enjoyed. And as in continuations to this, we'll continue to have many more such congress, which is upcoming in this year. We'll bring to you these current highlights on the day of the congress as soon as it gets over. Thank you so much. Thanks for joining with this. Good night. Thank you.